Disorders of the adrenal cortex arise from imbalance of three major steroid classes: glucocorticoids, mineralocorticoids, and adrenal androgens. Adrenal deficiency results from autoimmune destruction, infections, infarction, enzyme defects, surgery, or hypothalamic pituitary suppression. Hormone excess is mainly due to neoplasia, including pituitary adenomas, ectopic ACTH production, and adrenal cortical tumors. The adrenal gland is a highly vascular organ above the kidney, with distinct cortical zones producing specific steroids. Zona glomerulosa produces aldosterone, zona fasciculata produces cortisol, and zona reticularis produces adrenal androgens. Cortisol secretion follows a circadian rhythm controlled by the suprachiasmatic nucleus, with a peak in the early morning. The HPA axis regulates cortisol via CRH, ACTH, and negative feedback inhibition by cortisol itself. Dexamethasone suppression testing helps differentiate pituitary, adrenal, and ectopic causes of cortisol excess. ACTH stimulation testing assesses adrenal insufficiency by measuring cortisol response after synthetic ACTH administration. The renin-angiotensin-aldosterone system controls blood pressure through sodium retention and potassium excretion. Aldosterone increases sodium retention and potassium loss, leading to increased blood pressure and volume expansion. Steroidogenesis begins with cholesterol transport into mitochondria via SNR protein and activation of multiple CYP enzymes. Glucocorticoid synthesis progresses through pregnenolone to progesterone to cortisol via enzymatic conversion. Mineralocorticoid synthesis converts progesterone through DOC and corticosterone to aldosterone. Androgen synthesis produces DHEA and testosterone via sequential enzymatic steps in the adrenal zona reticularis. Cushing's syndrome represents chronic glucocorticoid excess from pituitary, adrenal, ectopic, or exogenous sources. Clinical features include central obesity, moon face, purple striae, proximal muscle weakness, and hypertension. Diagnosis requires screening with urinary cortisol, dexamethasone suppression, or midnight salivary cortisol testing. Treatment depends on etiology, with surgery for adrenal and pituitary causes and medical therapy for severe cases. Mineralocorticoid excess causes hypokalemic hypertension, often due to primary aldosteronism or adrenal hyperplasia. Diagnosis relies on aldosterone-renin ratio, followed by confirmatory suppression tests and adrenal imaging. Treatment includes adrenalectomy for unilateral adenoma and mineralocorticoid receptor antagonists for bilateral disease. Key takeaway: adrenal cortex disorders require understanding of hormonal axes, targeted biochemical testing, and cause-specific therapy.